Okay, so the first session of the year, everybody loves to hear about back pain. You may either have back pain, treat back pain, or have chronic back pain or pain that's just, episodic type of pain. So we're going to talk about various causes, how I evaluate them, management, and then we have our physical therapist who's going to go over some slides on some exercises that can be done to try to get you out of pain or maintain your back to prevent yourself from getting out of pain. I'm Jaideep Chunduri. I'm a board-certified orthopedic surgeon at Beacon Orthopaedics and Sports Medicine. I've been in practice for 18 years. It was surprised. Someone asked me today, have you ever done surgeries like this before? And I'm like, yeah, 18 years. So I don't know if I look young, act immature, I don't know. But it's funny because the patient was actually referred to me by my brother-in-law, who knows his patient's dad. So it was just kind of struck me by surprise that someone had asked if I had done that procedure before. But it happens. If you guys have any questions as we go along, I'm one of these people that will stop, and I'd rather have you answer it while we're on the slide. Just throw your hand up, just because I think it's much easier than trying to go back through all the slides. So basically, we want to understand a little bit about the anatomy of the lumbar spine. Understand various pathological diagnoses. What can you have that can cause you to have pain? Understand treatment modalities briefly, including operative and non-operative care. Again, I'm a surgeon, so my ultimate procedure that I can offer somebody is surgery. But as I said, that's the ultimate procedure I offer. We have various things that we offer prior to surgery, whether it be medication, whether it be injections, whether it be physical therapy, sometimes chiropractic care. So there's a lot of things that myself as a physician can take care of prior to the last option, which would be surgery. Understanding radicular versus axial pain. So we'll briefly talk about that, but the most common term that I hear in my office is, "Doc, my sciatic nerve hurts." And you ask them where to point, and they usually point to their lower back buttock region, and that's not, the sciatic nerve is actually below that. So we'll talk briefly about what that means, and so on. So what are the most common causes of back pain? The most common cause, and if you look at the literature, will tell you that 85% of people, general population, will have one episode of back pain in their life. And the most common cause is, you went out, you shoveled snow, you picked ice from the driveway, and your back hurts. So what happened there? You strained the muscles in your back, and you have pain. But on top of all that, even if you do quote-unquote injure the muscles in your back, you can also herniate a disc in your back. So what exactly is a disc? The disc acts as a shock absorber, and it's located between the vertebrae. There's two analogies that I use to try to help you understand what a disc is. Number one, the jelly donut. So you have the tough outer fibers of the donut with the jelly-like substance on the inside. So what is a herniated disc? You get a hole in that donut, and some of the disc material squeezes out and can push on the nerve, and that will give you pain. What are other terms that people use for a herniated disc? They can use, my disc is bulging, my disc is protruding, sticking out. I mean, there's many words we use, with the medical term being a herniated lumbar disc. The other way that I equate a disc is something called degenerative disc disease. And that's coming up here. So how do you equate what a degenerative disc is? So you take a grape, tough outer fiber, watery substance on the inside, similar to a disc. You take the grape out of the fridge, it's nice and crispy and tough. What happens if you leave it out an hour? It shrivels up a little bit, it loses some of that water, and then if you stick it out over days or weeks, if it doesn't fungus, you'll get a raisin. So that would be the equivalent of a disc that's completely collapsed and bone on bone. So that just is two good analogies to think about what a disc is like. Just like you can get arthritis in your in your knees and your hips, your shoulders, you can get arthritis in your lower back, and we call that spondylosis. Yeah, these things never work on the screen. Doesn't even work here. Okay. So what is spondylosis? That's where you get arthritis of the joints that are in the back of the spine. You can get shifting of the vertebrae back and forth because of that, because of how severe the arthritis is. It doesn't stabilize your spine. And it can also lead to something called spinal stenosis. Think of stenosis as the pipe at the bottom of your sink, which is clogged. So normally if you turn the water on, and the water in a brand new pipe, it will run very quickly through, and those are like the normal signals in your spine. Why is my Adobe Flash Player going off when I don't have it? But as grunge builds up in that pipe, you turn the water on, and the water will go really fast till it gets to that clog. It'll slow down. Once it gets past the clog, it'll speed up again. That's a very similar analogy for spinal stenosis. Okay. I give up. Give me just a minute. I don't like that sound. How's that? Trauma, car accident, skiing accident. You can injure the ligaments and the bones in your back. Car accident being the most common cause. And then one of the other causes that we see is secondary gain or psychological causes. My back's supposed to hurt, so it hurts. Secondary gain, again, you see that quite a bit, not as common. So when we look at the anatomy of the spine and all the muscles, we see that there's multiple layers of muscles. So if, for instance, you injure yourself right here, you can imagine with this muscle, you can feel the pain anywhere from here all the way down. So even though you may injure yourself at the mid portion of your lower back right here, you may feel the pain up and down. Also, when we get up into the neck, all these muscles up in your neck, again, go all the way down through your lower back. So oftentimes patients will injure themselves in the mid-back, and they'll say, well, I feel the pain going up and the pain going down. But in reality, the pathology is probably somewhere in the middle. So the complex anatomy makes things a little bit more difficult. Okay. This is a side profile view of the spine. And so this place right here is called the vertebral body. It's the bone that makes up the front of the spine. In between each of the bones, we have the disc. I already talked about what the disc is. And surrounding the disc are ligaments that help hold it in place and keep it strong. In the back of the spine, so the spinal column, the spinal cord and spinal sac with all the nerves runs right through the middle. And then the back of the spine, you have these joint surfaces called the facet joints. The facet joint is what can give you arthritis in your lower back. So again, this is a back profile view. So the spinous process here is that bone you feel right down the middle of your back if you run your finger down the middle of your back. And then we have the joint surfaces on each side. The transverse process is where all the muscles attach to. And then you may have heard of someone having had a laminectomy. What does that mean? Well, there's a bone called the lamina, which is basically forms the back portion of the spine, and then ectomy means you've removed it. So basically the back portion of the spine, the lamina, is kind of the ceiling of the spine if you're looking up. So in addition to bones and discs, we have ligaments. We have what's called the posterior longitudinal ligament that helps hold the spinous processes in place. You have the inner spinous ligament, which is between the spinous processes. And then you have this thing called the ligamentum flavum. The ligamentum flavum means yellow ligament. And literally when we take it out, and I remember back in training, we used to pass it off to the student nurses and let them feel how thick it is, and it really looks yellow. And that can be a source of a lot of spinal stenosis, because what happens is when you get arthritis in your back, your body has to compensate in some way to prevent things from moving abnormally. So it can make, you may have to work on getting your muscles stronger. But what your body does is it can thicken up some of the ligaments. But when you thicken up a ligament around a nerve, it can cause it to get pinched. And so the Ligamentum Flavum is a culprit in having back issues and what we call radicular pain. So let's say we go and injure our back. What are the treatment modalities? Well, this is where you need to figure out what's the cause of the pain. What kind of pain am I having? Are we having what we call just axial back pain? Pain just in the muscles of your lower back or the surrounding areas or right down the middle? Or is it what we call radicular pain? Radicular pain means pain that starts in your back and shoots down into the leg, into your foot, or it can start in your neck and move into your arms. If it's from your mid-back, it can move around your chest wall across your ribs. So it's very important to know what is the pain, where is the pain. I want you to trace out the pain for me. Is it in the front of the thigh? Is it on the side of the thigh? Is it down past your knee? Is it to your foot? Because if we get those details, it'll give us a better idea of what the cause is. Is it there all the time? Is it only there in certain positions? Is it when do I get the pain, or do I feel like my leg is going to give out? So again, those are important things that we need to know when looking at back issues. So the treatment modalities are wait and see. Most of the time back pain will get better. Sometimes it takes 4 to 6 weeks, but most of the time it gets better. Medications that we typically use are steroids, anti-inflammatories, muscle relaxers. Occasionally you'll use narcotics, Tylenol, and then there's all these different nerve medications that you can use as well. We have physical therapy. We order lots of physical therapy in our office, and it's one of the mainstays for treatment for everything, not just back issues. We also have alternative treatments. Those things are things such as acupuncture, chiropractic care, yoga, and so the one thing we don't recommend is rest. Go home and lay down for 10 days and you'll feel better. Definitely not. We also have epidurals, which are basically taking a steroid injection. So some people call it an epidural steroid injection. Some people call it a cortisone injection. Some people call it, other names for it. But the biggest thing there is that you're putting medication around the nerve. You're not putting it into the nerve. You're putting it around the nerve. But all it does is take away inflammation. It does not eat away at the arthritis. It does not eat away at the disc. But it helps decrease inflammation around the nerves. That's why sometimes it's temporary. That's why sometimes it doesn't help. And then the last option is surgery, which there's various different types of surgical procedures that can be performed. Okay. So, lumbosacral strain, low back pain. It's an injury to the paraspinal muscles. That's the muscles that run along the side of the spine and any of the supporting structures of the spine. Typically I'll use the words strain and sprain interchangeably. Sprain tends to be ligaments. Strain is more tendons. Provided that you have isolated back pain, and if you subsequently get an MRI, patients should get better with time, physical therapy, or any type of alternative treatment. If conservative treatment does not occur, or if patients have pain that shoots down in their legs, then we typically go for a more aggressive workup to try to figure out what's going on. That's where we order MRIs. You may have heard of something called a CT myelogram. That's patients that have pacemakers or defibrillators that are not MRI safe. We end up doing what's called a CT myelogram. That's where we inject dye into their spinal sac and get a CAT scan afterwards, and you look to see where that dye is getting pinched. And we also have an EMG, which is a nerve test. It's a relatively non-invasive test, although they do put a needle in the muscle. And basically it allows us to find out, is there a blockage of the nerve conduction signal someplace that will give us a clue as to the cause of the pain. Again, lumbosacral strain usually improves with time, although therapy can help the patients deal with the symptoms and get stronger at the same time. One of the key things here with physical therapy, and I tell patients, I've had patients that have pain for 15 years, they come in and they're like, well, how's physical therapy going to help my pain for 15 years? Well, it may not necessarily help all of your pain, but most of the time we see that patients get 70 to 80% relief of your symptoms. So if you go from a 7 out of 10 to a 1 or 2 out of 10, that's pretty successful. Or for those patients that get episodic pain, like every time they go out and do something physical, they get pain. Well, by doing the therapy and strengthening your core muscles, what we find is that their episodes of pain or severe episodes of pain go down. And if they do get into pain, they typically know how to get themselves out of pain. If for some reason with the strain we don't improve, or there's a plateau in treatment, you go from 8 out of 10 pain to 4 out of 10, but you still have the pain, that's when we typically would recommend an MRI. Okay. Herniated disc. Again, if you look at the population above the age of 40, 60% will have a herniated disc. And these can be asymptomatic, meaning you don't have pain from it. These are just, in the past we used to just get random MRIs on people, even if they didn't have pain, and you found that the disc may be herniated. The natural history is that most pain due to herniated discs resolve. Again, sometimes with treatment, sometimes without treatment. And it's rare that we, even though I do surgery, it's still very rare the number of herniated discs that we see compared to the number we actually operate on. This is kind of words that you may hear, bulge, what we think of kind of the disc sticking out just a little bit as a bulge. If it protrudes to one side and there may be some tearing of the fibers of the disc, you get what's called an extruded fragment, or you may have heard the word free fragment, and that's what sequestration is. There's different terms for the type of herniated disc. Okay, arthritis of the spine we talked about. This is one of the key things with what we call facet joint arthropathy. So just like you can have arthritis in the knee, you go in and replace the knee, the pain gets better. Unfortunately, we don't have that ability in the low back to go in and replace that arthritis. There are procedures called facet arthroplasties where you can actually go in and replace it. They're not very common, and it's just we're not sure how much relief patients typically get. One of the more common things that I see is spondylolisthesis. This is due to arthritis. And if you look at the back, if you look at the lineup of the vertebrae, if you look at the back of these two vertebrae, they typically line up. But when you see this vertebrae compared to this vertebrae, it's shifted forward. So that's kind of one of the hallmark reasons why we operate, is someone that has an unstable spine. Now that instability can be due to trauma, it can be due to degeneration, or oftentimes we'll sometimes see it in teenagers from stress fractures in the back. Spinal stenosis or tightening of the nerve. So one of the common things that we see is patients that have spinal stenosis oftentimes can't walk more than a block or two. Why? Because when they start walking, they get inflammation around the nerves and it sends the pain down into the legs. Oftentimes this can get confused with what we call vascular claudication, meaning the blood vessels are clogged and that they can give you similar symptoms. But one of the hallmark signs of spinal stenosis is, going to the grocery store, you can only go one aisle without a grocery cart. But give yourself a grocery cart, you're hunched over a little bit, that opens up your spine, you can do the whole grocery shopping and go home without significant pain. You have a question? Or?
No.
Okay. Epidurals are a very good option, especially in patients that don't want surgery. I'll have some patients that come in every 3 months, get an epidural. They get 3 or 4 a year, and they do pretty good. This gives you an idea, again, of a normal spinal canal up here, and then how it gets tightened over a period of time, either due to the disc bulging out, spurs, ligaments, or the arthritis. Degenerative disc disease. This is a perfect example of the grape coming out of the fridge versus the raisin. You can see how the discs are completely collapsed. Again, 60% of people above the age of 40 will either have a degenerated disc in their neck, their mid-back, or low back. So just because you have a degenerated disc does not mean that you have pain. And that's one of the hardest things we deal with. If I get a patient that's had severe back pain, they get all their testing, and the only thing you see is degenerative disc disease. I just told you that degenerative disc disease is not a cause of back pain. Well, now I got to go prove that patient's degenerative disc disease is causing their pain to the insurance company. So even though we say that most of the time it's not the cause of back pain, it can be the cause of back pain. Trauma, that's kind of beyond the scope of here. So physical therapy, we concentrate on lumbar extension exercises as well as abdominal exercises, your core. If your core is strong, you tend to do better. One of the things in the past I used to always harp upon is I'd have a patient that went to therapy and I'd say, okay, so what did you do there? Well, they kind of massaged my back, they did some ultrasound, they put a stimulator thing, and then they sent me home. To me, that's not the hallmark of physical therapy. That's more you feel good while it's on, and then the pain comes back. So the mainstay of treatment should be stretching and strengthening rather than, as I say, the feel-good modalities. And then the other thing at the very bottom is promoting cardiovascular conditioning. A lot of patients with chronic back pain, they haven't done much because it hurts to do things. Let's find some exercises to do that will help us improve our overall function and cardiovascularly. So whether it be bicycle, whether it be swimming, whether it be elliptical rather than walking, running, jogging, those kind of things. Okay. Pain management, one of the things that's very important is sleep. So, we don't like using medication for it, but sometimes you have to. Medications, as I said, opiates, those have kind of fallen out of favor because of the opioid crisis. Anti-inflammatories, antidepressants, and anticonvulsants. Neurontin, gabapentin is a mainstay of one of the medications that's used. So, smokers tend to do poorly with conservative and operative management. The theory is there's poor healing and less likely chance of effusion, secondary to poor microcirculation. And I know some surgeons that won't, that's one of the big tests that we get prior to surgery, and some docs won't even operate on a patient if they smoke. You've heard of a laminectomy. So again, what we've done is opened up the entire middle portion of the spine to give the nerves more room. Here's what's called you can see a laminectomy here. So up here you see the ligament covering and the entire joint surface. Here we've taken off part of the joint and opened up the space around the nerve. Sometimes we can do a fusion. These are borrowed x-rays, not mine. But there's various types of instrumentation that can be done for that. And then we also have, in younger patients, 45 and less, we have what's called a disc replacement that can sometimes be performed. Again, if the pain is, we can find the one area of pain. There's multiple approaches to doing surgery, and it's individualized based upon the patient. So we're going to skip all the surgery stuff. Some people ask about minimally invasive surgery. What is it? Some people equate minimally invasive surgery through something that can be done with a Band-Aid. You heard of the Laser Spine Institute, where they, basically they were doing things through a small incision, not necessarily with a laser. Many surgeries can be done minimally invasive. Some people would even consider when we go through the front to reconstruct a disc that's minimally invasive because we're not cutting muscle, we're going around everything. The word percutaneous you may hear of, again, something done through a very tiny incision without opening up the skin. Everybody always asks, can you put a scope in there and take something out? And that's coming back into About 10 years ago, 10 or 12 years ago, actually even longer, 18 years ago when I first came out of training, I was working with a doctor out in California that was doing a lot of scoping of discs. And I learned the technique, and it was one of these things where, I just don't feel happy doing this. It's like, yeah, you're taking out some stuff, but you don't really know what you're taking out. But I would tell you that in the next 5 years, you're going to see things such as endoscopy coming back as the techniques have gotten better. You're going to see robotic surgery, spinal navigation, and then the thing that I'm excited about is augmented reality. So it's like a video game. So I can look down at someone's spine, and you can basically see what the anatomy looks like, which will help you put instrumentation in and hopefully reduce radiation exposure in the operating room. So do you guys have any questions before we move on to our therapist, who can answer a lot of what we want to know about what kind of exercises we need to do? Yes?
Talking about shots. Now, what's the limitation? Is it still after so many years you've got to give it up and get an operation?
Yeah, so that's one of those things. Everybody has a different opinion as to what should be done on it. The studies have shown that if you do more than 3 or 4 epidurals in a year, the chances of having other issues,
yes,
i.e. they say the adrenal glands don't give you the natural cortisol. But I've personally never seen it clinically, but I still try to limit my, 3-4 injections a year in a given spot. Let's say someone comes in and we take care of their back, but then their neck bothers them. Well, you don't want to just say, well, you've had 3 injections in your lower back, we can't do injections in your neck, let's go do surgery. It's a hard thing to sell, especially if they've been successful in the lower back. So I kind of take things on an individual basis. We look at their medical problems. If you're a bad diabetic and every time we give you an injection your blood sugar goes through the roof, we're not going to probably recommend steroid injections. I've had patients that get like spinal headaches afterwards or severe pain where they end up in the emergency room because of the reaction. Obviously, so we have to take things on an individual basis. Any other questions? You're up.
Hi everybody, my name is Kristen Arvison. I'm a physical therapist with the TriHealth Orthopedic and Sports Institute. We're located here at the Sports Center on the 2nd floor. We share an office space with Beacon actually. I've been a physical therapist for 8.5 years and I'm board certified in orthopedics. So I've seen quite a bit of low back pain over the years. And so today I wanted to follow up Dr. Chunduri's talk where he talked more about the different diagnoses and specific interventions for low back pain. And I kind of wanted to talk to you all about certain things that we can do to protect your spine and prevent low back pain, as maybe you're looking to start a new program at the beginning of the year, or maybe with COVID, you've held off on exercising for the last 8-9 months and are looking to kind of pick back up where you left off. So just some of the objectives, I do want to review with you just some general exercise guidelines for everybody, and then kind of go over the role of the spine, and then some things that you can do should you develop any spine pain while you're working out or doing just other activities around the house or the yard. And again, if anyone has questions, feel free to interrupt or ask a question. I'm happy to answer them as we go. So overall, the American Heart Association recommends that all adults get at least 150 minutes of exercise a week. So maybe that's our new goal going into the new year, is to work up to that number. So basically that breaks down to 30 minutes a day, 5 days a week of moderate exercise. And that's like riding a bike at a slower speed, or a brisk walk, or water aerobics. If you like more high intensity exercise like running, jump roping, swimming laps, they recommend about 75 minutes of that. And as Dr. Chunduri talked earlier, he said the cardiovascular benefit of exercise is really important for your back health as well. The American Heart Association also goes on to say that adding stretching into your routine is incredibly important, as well as at least moderate to high intensity strength or resistance training at least 2 days per week. So if this is our goal and we're looking to get into this weekly minutes of exercise, we want to think about what our spine's role is during activity. And to break it down the most simple way I can, the spine essentially has two main roles for exercise and activity. So its one role is support, so stability, and that's going to be for your trunk, your upper extremity, and your neck. And this is provided by the active work of some of those core muscles that Dr. Chunduri described earlier. And its other main role is flexibility and mobility for movement. So, for example, if I'm just bending forward here at my waist, not even considering my neck, there are 16 different segments that are at play, and each of those segments has about 3 different joints. So we're looking at 48 different joints that have to move just to bend forward. So we need to make sure that our spine has the stability and core strength, but it also has to be very movable and flexible. So as you can imagine, that makes it kind of a challenge for the spine with those sort of 2 different roles it has. So as you're going into starting a new program, you want to make sure that you're considering both those roles. You need to have a flexible, mobile spine, but also a strong and stable spine. So the first thing I want to talk about here is the stability and the strength factor. So your core muscles are what actually control our spine and initiate movement. They help transfer and dissipate forces through our bodies, and they help determine our posture, and they also prevent us from moving abnormally or incorrectly. A lot of times when patients come in and see us in therapy, we notice that we find some pretty common muscle imbalances, and that can put more load or more stress on different structures or muscles of the spine or the hips or the knees. So for example, one of the common muscle imbalances that we tend to see is weakness in the gluteal muscles, so your buttock muscles, as well as some of the muscles deep in the abdominal cavity, like your transversus abdominis. So what can happen with that is patients may come in with a bit of a postural abnormality. So if those glute muscles are weak, it may pull our back into more of this increased extension or lordosis, and our hips rotate forward. It puts a lot of strain on some of those joints of the back that Dr. Chunduri discussed earlier, and that's going to cause more pain if you're in that posture and try to run or jump or do the elliptical or any other activities you might be getting back into. So one of the most important things you can do is learn how to engage those core muscles and create a nice, strong, healthy core before you go into some of your exercise activities. So here's just some examples of some core stability exercises. And again, these are just examples. Depending if you already have some maybe pre-existing conditions or you've had back surgery, it's always important to talk to your provider or a therapist before you maybe start a routine. But the first one there is an abdominal brace. That's one of the best things you can do. This is just drawing your belly button in, tightening up the muscles around the core, and that protects your back. So that abdominal bracing is something we should be doing even before we lift something off the ground or before we bend over. Just engaging those muscles will help protect the structures of the spine. And those are just some progressions across the screen. So you can add some leg lifts with your abdominal bracing, doing some bridges. That helps offset that muscle imbalance in those gluteal muscles I mentioned earlier. To increase the challenge, here's some more weight-bearing exercises like a bird dog. It's a very common yoga or Pilates move. A little more dynamic, work some of those deep muscles of the back, and then of course your planks or your side planks. Okay, so now that we've covered the importance of getting a nice, strong, stable core, we also want to talk about now the mobility and the flexibility surrounding the spine. So again, the lumbar spine has 5 different vertebrae. Those vertebrae are separated by discs, which kind of absorb shock and help guide movement. The primary movements within our spine, the biggest one based on just the orientation of those joints is going to be just your forward bending, your flexion, or your extending backwards. But the spine also has to allow for some side bending and some rotation. So you can imagine that if any one of those joint segments is a little bit stiff or not moving the way it's supposed to, that's going to create increased stress on the joints perhaps above or below, and that can cause muscle strains or joint pain, and just kind of extra load on some segments that aren't meant to sustain that type of load. So moving forward, we talked about the mobility of each spinal segment. We also want to have good flexibility around the muscles that attach to the spine or to the pelvic girdle. So one big thing maybe you all have heard about is your hamstring tightness. A lot of people come in and say, I have tight hamstrings. Well, research shows that tightness in the hamstrings is directly related to low back pain. One of the causes for that, so the hamstring muscles come and attach at the back of your hips. They help extend your leg backwards. So when you go to bend forward, if those hamstrings are tight and they stop me moving here, if I want to reach forward, now my back has to move a lot more to accomplish that task. So it really loads the spine, increases pressure on the discs within the spine. It can cause disc problems or more of a muscle strain, some of that lumbosacral strain Dr. Chunduri was discussing earlier. So it's really important to include some of those mobility exercises for each segment of the spine, as well as stretching around the muscles that attach in and around it. So prior to exercise, a lot of times people ask, when should I stretch? Should I stretch before? Should I stretch after? How long should I hold them? The biggest thing that we found from research is that before you exercise, a dynamic warm-up is going to be the best approach. And so what that means is just kind of general gross movements to get your body used to the activity you're about to ask for from it. So that might be some kind of walking lunges or arm circles or kind of hugging your knee up to your chest as you're moving, just to prepare your body for movement. After you do your exercise, once your body is warm, that's when it's best to do the static stretching. And I have some examples on the next slides, but a static stretch is something you're going to hold typically about 30 seconds to a minute, and that 30 seconds marker is what's required to get some actual tissue elongation and have some lasting effects. So going back here, these are some mobilization exercises. So this is aimed at making sure those segments of the spine, each vertebrae, moves kind of appropriately on the next one. So some lower trunk rotations. It's a great warm-up for the spine. Sometimes first thing in the morning, a lot of patients love doing these. They feel great. Again, if you've had back surgery, you may have precautions from your surgeon not to do certain movements. But of course, talk to your doctor before starting any of these. The cat-cow is also a great one. It gets that spine prepared for flexion and extension, which is one of the prime movements of the back. And then pelvic tilts. Again, it's more of a postural re-education exercise, but also gets the segments around the spine and the pelvis moving a little better before you start doing more demanding exercise. And then just some more static stretching. So again, at the end of your therapy or end of your exercise session, these are stretches you can hold 30 seconds or so, 3 to 5 times. That first one there is one example of a hamstring stretch. There's lots of ways to stretch your hamstrings. This is a really great one. If you already have back pain, it's minimal load on the joints, and you can kind of control that stretch a little better. The next one is called the Piriformis Stretch. There's different ways to do that as well, and that can be modified depending on your flexibility. A lot of times that muscle called your piriformis, it's sort of deep in your buttock. And if that's tight, that can sometimes increase some nerve pain going down the legs or just kind of cause some discomfort in the hip area. And then the last one is a hip flexor stretch. That's for the muscles across the groin, where again, if those muscles are tight, that might pull your pelvis into kind of an abnormal tilted position, causing more strain on the back. Okay. So just general other kind of tips and tricks for protecting your spine as you're maybe moving into a new exercise routine. Biggest thing is start slow. I would say that's when patients come into therapy and we're asking questions of when did your pain start or was there any change in your routine? A lot of times it's either starting something up too quick or lifting too heavy, or maybe they took a long break from exercise and thought they could go back to where they left off, and that tends to put them at a little higher risk for re-injury. So when you're starting out, less weight's better, higher reps. Maybe bring a buddy with you to help you spot to make sure your form's right. And then even sometimes those training machines are a little more controlled and safe versus just the free weights. If you want to get back to weightlifting, it's important, or really any lifting at all, to keep your objects close to your body. Holding something that's heavy away from your body puts a lot of stress on the low back. So keeping the load close to you, that'll help protect your back and decrease some of that load on those joints. We talked earlier about maintaining good core strength. So doing that abdominal bracing, tightening up those muscles, pulling that belly button in, squeezing your glute muscles when you bend to pick and lift things up, that's really going to protect your back too, especially with shoveling snow or I guess it's not time for yard work yet, unfortunately. But anything you might maybe have to lift, that'll keep you a little safer. Everyone knows to bend at your hips and at your knees, never bend leading from your trunk. Another big thing to do is vary your exercise routine. We all are creature of habits. I know I'm guilty of it. I like to do the same thing over and over, but our spines aren't meant to handle, our bodies in general aren't meant to handle the same repetitive stresses over and over. So if you can vary your routine if you like to do the elliptical one day, maybe do swimming or biking another day, or get the weight training in. But varying the routine is very important for just overall wellness. Diet and lifestyle, talked about this earlier. Avoiding smoking is probably one of the biggest things and best things you can do on multiple levels, but especially for your spine. There's a huge link with low back pain and smoking, so that's something to consider as you're moving forward and trying to prevent your back pain. And then the biggest thing is listen to your body. People come in all the time to therapy and say, well, no pain, no gain. It's just part of the rehab, and that's not necessarily true. So just being aware of what your body is telling you. Muscle soreness that happens 48 hours after exercise, very normal. It should go away with time. But if it's a shooting, stabbing, nerve-related sharp pain, that's not normal, and that's something that you need to kind of stop and pause and look at your body mechanics, look at what you're doing, and make some changes if necessary. So if you do get back pain, you're not alone, because at least 80% of people will have low back pain sometime in their life. But the research shows that 90% of people will fully recover, so that's great. So things that you can do should you start a new routine and get some back pain. First, stay active. Like Dr. Chunduri said, bed rest isn't really an option anymore. That's what we used to tell people, but now the best thing you can do is stay moving. So light activity, whether it's some stretching, walking, recumbent biking, whatever feels good, but something to keep the muscles moving, get the blood flowing, will actually help you heal and recover a little more quickly. Icing can be appropriate. If you have an acute strain, so something that happens, you bend and you have a sharp pain, icing 10 to 15 minutes can help alleviate some swelling and decrease some of the pain that you're having. Patients that have more chronic pain or stiffness, heat can also be used, but for any kind of sudden onset pain, ice is usually better. Consider your body mechanics with lifting and carrying, even if it's just sitting in your home office or if it's carrying groceries, be mindful of that. Get plenty of sleep. That one is oftentimes left out. I know if you have back pain, sometimes it's hard to sleep, but definitely try to get those hours in. Laying down in that supine flat position takes pressure off your back, and our bodies also do a lot of healing while we're resting. And then the other thing you can do is, I know the health club offers, or they're looking to offer, I think, some injury screening clinics. You can see a physical therapist or a personal trainer. If you're working out with a personal trainer and you have questions about the routine, you can always talk to them and see what modifications could be made. So finally, every now and then, that 10% that maybe doesn't get better, these are some reasons why you would maybe want to follow up with a specialist. So if your pain comes on and it's not leaving after 4 weeks, or if there's no change in position or no movement or medication that can alleviate your pain, if you all of a sudden have changes in bowel or bladder, night sweats, or weakness in your legs, then it might be time to consult with your doctor. But the good news is most pain does go away within those first 4 to 6 weeks. And again, I put on the bottom, if anyone here is already suffering from back pain or has had surgery or any other pre-existing injury or condition, it would be important to talk to your provider before you start a new routine. But that's all right now that I have for you guys. I appreciate your time. Are there any questions I can answer specifically about exercise? Yeah.
Crunches. I have stenosis in the neck, and I know this isn't low back.
Sure.
Crunches. Good or bad? I read all kinds of stuff when I'm doing Pilates. Is that a good thing or not?
That's a great question. So traditionally, sit-ups I would probably not recommend. A full sit-up is really a lot of work on the hip flexors. It puts a lot of pressure in the low back. But doing a crunch safely, so if you're laying on your back, and we talk about that abdominal brace, so having good posture, supporting your neck, not pulling your neck forward, but keeping your neck nice and neutral and supported, that should be safe for you, as long as it's not painful and you're not having any symptoms down the arms. And so with that crunch, you're not doing a full-on sit-up. You're just kind of lifting your shoulder blades off the table or the mat and coming back down. But yeah, you should never be pulling on the neck. that might increase pain.
Okay.
Yeah, it's a good question. Yeah.
Does
I have a problem with balance. Would that
Sure.
have something to do with my back? I've had surgery on my back, or anything that you would recommend to help with your balance?
Absolutely. So there's a lot of stuff you can do with balance, and some of it does have to do with core stability. You've had back surgery, you said?
Yes.
Yeah, so any time that you have to cut through or around muscle, just even that initial trauma of the surgery and the swelling, that can cause muscle inhibition and kind of almost delayed firing of those muscles. So those muscles, those core muscles, also help stabilize you with your balance. So if you there's things you could do, if you have a stability ball, you could do some exercises either lying on a stability ball or sitting on it. That would challenge your core a little bit more. You could vary the surface you're standing on. So if you like to do some standing exercises, even putting something down that's maybe a little like a balance pad, something a little squishier, that would make you recruit more muscles to work on your balance. Those are just kind of some ideas to get you started, but definitely working on engaging those core muscles and those gluteal muscles. Those will help keep your balance a little better. So normally if someone like steps and they kind of lose their balance, those hip muscles and core should just automatically kick in to help keep your trunk upright. If there's a delay in that firing pattern, that could make you fall over. So
would you recommend yoga?
Yoga's great. So it depends, again, I don't know what kind of surgery you had, so there may be certain movements that you'd have to maybe modify or avoid. But yoga in general is really, really good. It works on flexibility, core strength, a lot of the things that get neglected with the typical like cardiovascular running and like elliptical program. Yeah, you're welcome. Anybody else? Yeah.
You have a set of exercises that we might get that gives us some good roadmap for back exercises. I know you showed a few, but to remember those tomorrow or the day after.
Sure. Yeah, I'd be happy to talk to you after this. We can talk about maybe some things that might be good for you, if that works.
Okay.
Yeah, absolutely.
Good.
Yeah.
So one of the, again, I remember a few years ago, and this is just an example, this may not pertain to everyone here, but I saw about 15 football players from the same school all get hurt doing squats. And luckily none of them fractured their back, none of them had herniated disc, but literally 15 kids all within a week. And so what we found is, going back, it was the technique. So squats is a very technique-dependent exercise. Would I recommend it? Well, possibly, yeah. I mean, we all, any trainer you work with is going to want you to do squats, but it doesn't necessarily have to be with tons of weight. Just body weight is good enough to get, again, your muscles moving. But it's one of those exercises that, kids try to put so much weight on, technique is off, and again, 15 kids all within a week or 10 days all injured themselves at a high school, and that throws all their practices off and everything like that. But if it happens to you, again, you may have severe back pain that doesn't go away. So I tell patients with back issues, avoid deadlifts, avoid squats with any type of heavy weight. So, and heavy weight to me is more than body weight. So for our trainer at our school, watch out for those kids. Luckily you're at a school. Yeah, luckily you're at a school that they don't weight lift a lot. So.
That's right.
Okay.
But it's so exercises are very technique dependent. And my point is that you got to do them right. Watch a video on how to do them. Work with your trainer on how to do them. Work with the therapist on how to do them. But very, very important to do the exercises correctly in order to prevent yourself having more pain, or if you're doing it preventatively, to prevent yourself from getting into pain.
Are there videos, YouTube things that might be available for
There,
different exercises?
there certainly are. The internet is a curse and a blessing at the same time. So if you Google the 5 best exercises for low back pain, you're going to find different exercises on a million different web pages. And a lot of it is dependent on what your condition is and what's causing your pain. So there are the ones I put on here are kind of generally safe exercises that most patients can benefit from. But if you're someone who has a herniated disc versus someone who has a spondylolisthesis, your exercise program might look very different because of the nature of the injury. So I know it's kind of a long-winded answer. So to answer your question, yes, there are good videos on the internet, but it's important to kind of know which ones are best for you. And so if you're looking at some exercises on the internet and something hurts, something doesn't feel right, I would definitely say to stop and not do those. It's probably best to find exercises on the internet, if that's an avenue you want to look down, that come from a reputable source, like maybe from if Beacon Orthopaedics has exercises on their website, or if TriHealth Orthopedic Therapy has exercises on theirs. Those would generally be more safe than just going on like a YouTube and Googling or searching what's the best exercise. Yeah. Any other questions I can answer? Okay. Well, thank you, everybody. Appreciate your time.
Thank you.